So anemia is the reduction in hemoglobin resulting in pallor or weakness. The basic concepts we need to understand are hemoglobin normal in women is 11 to 16.5 grams percent, and in men it's 13 to 18 grams percent. The reticulocyte count is 0.5% to 2.5%. Reticulocyte production index is what we actually calculate when you're given a reticulocyte level. Supposing the patient has a hemoglobin of, say, 10 grams percent, and the reticulocyte count is 5%. It doesn't mean that he has a hemolysis. We actually have to calculate the corrected reticulocytes and the reticulocyte production index. We do that by multiplying the reticulocyte given, say it's 5%. You multiply that with the given hemoglobin of the patient divided by the reference hemoglobin, which we will take as 15 grams percent. And the whole factor has to be divided by 2 to get the actual corrected reticulocyte production index. And this is the value that we need in our concepts here. MCV, which is the mean corpuscular volume, is 80 to 100 spicoliter. MCH, which is mean corpuscular hemoglobin, is 27 to 32. And MCHC, which is mean corpuscular hemoglobin concentration, is 32 to 36%. And we get that by an MCH divided by the MCV. MCV and MCHC, they correlate. A WBC is 4,000 to 11,000 per microliter, and platelet count would be normally 150,000 to 400 to 450,000 per microliter. This is what a normal blood film looks like. And there you can see there's a pallor of the red cells, and they are disc-like cells. You'd see very few platelets on the blood film. You'll also see 1 or 2 WBCs. This is what reticulocytes look like. They have RNAs, fragments of RNA remaining, and this is stained with cressyl blue. In severe iron deficiency anemia, you not only see tiny cells, which are called microcytes. You can see the small cells are called microcytes. You'd see them hypochromic, which they have more pallor compared to the usual cell. They're very pale in the center. And they are anisocytic. Anisocytosis means the sizes vary considerably. And this coincides with the RDW, which is the red cell distribution width. So the higher the RDW, the more the anisocytosis. Poikilocytosis refers to the difference in the shape. The shapes differ so much. You can see some look elongated, some look short, some look oval. The difference in the shapes is what is called poikilocytosis. This is the picture of severe iron deficiency anemia. Macrocytic anemia, typically you will see, compared with a lymphocyte that we see at the bottom of the film, you see it's bigger. The cells seem to be bigger than the lymphocyte. And if you see, there is no hypochromia. In fact, the hemoglobinization seems to be almost throughout the cell. This is typical of megaloblastic anemia. In megaloblastic anemia, in the film, you will also see hypersegmented neutrophils. And there could be a drop in the platelet count as well. Target cells, these have a bullseye appearance. And this is seen typically in thalassemia and in chronic liver disease. The broken up cells that you see are called helmet cells or schistocytes. And this is a picture that you will see in fragmentation syndromes like hemolytic uremic syndrome and thrombotic thrombocytopenic purpura. You'll also see it in HELP syndrome, which is seen in pregnancy, and thermal injuries and malignant hypertension. Burr cells are seen in uremia. These are also called echinocytes. Now, you could get a multiple choice question with both these pictures, the top and the bottom. The difference between them is, I'm sorry, I don't have a pointer, but the Burr cells on top, the spicules are equally distributed around the cell. If you see, there's one right in the middle. And in a spur cell, or the acanthocytes, which are seen in severe liver disease, the one slide at the bottom, the spicules are not equally distributed throughout. They're not spaced equally. So you'll find them randomly located. Those are acanthocytes or spur cells. So what do we look for in a history of anemia? First of all, we take a good diet history. We want to know if the patient is non-vegetarian, how often he takes non-vegetarian food, does he take red meat or no, and is he a pure vegan? Pure vegans have a likelihood of developing B12 deficiency. Menstrual losses are very important. We need to take a detailed history from menstruating women about the number of pads changed, the amount of losses, how frequently does it happen. Dark stools and blood in stools. Dark stools, you would think of peptic ulcer disease. Blood in stools, we would think of, especially in a middle-aged to an older person, blood in stools and anemia with no other history, we have to think of colon cancer. Of course, the more common reasons of blood in stools, if there's just frank blood in stools and nothing else, no change in weights, you would think of hemorrhoids rather than cancer. Recent history of weight loss is very important, not only for evaluation of cancer, but also in chronic anemia of chronic disease. Any chronic inflammation can cause weight loss, which can also cause anemia. Altered bowel habits, a patient who has constipation and alternating with diarrhea, we think of bowel cancer, colon cancer. Sometimes a right-sided colon cancer can present pretty late because they did not have any change in bowel habits. They sometimes present only with anemia. And if you check a stool for occult blood, then that turns out to be positive. We end up doing a colonoscopy and we find it. History of color-colored urine. If the patient sometimes doesn't complain of it, and we need to actually ask them, have they had a history of color-colored urine? Because that is indicative of intravascular hemolysis, not extravascular, but intravascular hemolysis, because hemoglobin and hemosiderin is being released into the urine, and that's why it's color-colored. Now, color-colored urine, if the patient has that, we have to ask that if it is particularly present in exposure to cold, or if it's present at night, because paroxysmal nocturnal hemoglobinuria would occur in the night, and paroxysmal cold hemoglobinuria would occur at exposure to cold. History of rashes are important because, first of all, there could be petechial rashes indicating that the platelet count is also low. So we're not just dealing with an anemia, it could be a pancytopenia. Rashes can also occur in other diseases, like in cancer, in leukemias, you can get rashes. You can get rashes in autoimmune diseases, which can cause autoimmune hemolytic anemia. Fever and night sweats, this is important, especially when we're thinking in terms of a leukemia or a lymphoma. And also in chronic inflammatory diseases like TB, also, which can cause anemia. Bone pain, lymph node swellings are important. Sometimes the patient tells you that I've got some swellings on my neck, I have got some swellings on my inguinal area, or in my elbow. So they tell you, and then you have to figure it out. Bone pain is typically seen in patients with leukemia, and they have sternal bone pain typically. Joint pains, malar rash, and photosensitivity for a history of SLE. Intake of certain medications like methotrexate, trimethoprim. Trimethoprim is a drug which is commonly used in the UK for a treatment of urinary tract infection, which is not complicated. Some people are even put on prophylactic trimethoprim for if they have recurrent urinary tract infection. This predisposes to folic acid deficiency, which causes anemia. Family history of anemia is important in hereditary conditions, and what type of transmission is also important, because X-linked recessive diseases are G6PD deficiency, and autosomal dominant ones are hereditary spherocytosis. The family history of anemia is very important. History of gallstones or gallbladder surgery is also important, because this would be indicative of hemolysis going on in the body if it is pigmented gallstones. Coming to the examination, we have to examine for pallor, for jaundice. On the face, we have to look at any rashes. We have to look at the gums for any hyperplasia. We look for lymph node enlargements, generalized lymph node enlargements, starting from under the jaw, the Waldier's ring, and the lymph nodes around the neck, supraclavicular area, axillary, supratrochlear nodes, and inguinal nodes and abdominal nodes if we can feel any. Anemia is classified on the basis of a reticulocyte production index as a production problem or a loss problem based on whether the RI index is less than 2.5 or more than 2.5. If it's less than 2.5, there is a production problem, and it's further classified as normocytic or microcytic or macrocytic. If there is a loss problem, it's either due to a hemolysis or due to a bleed. Normocytic is when the MCV is normal. If you do a bone marrow analysis in these cases, you will find the myeloid erythroid ratio is more than 2 to 1. When the MCV is low or the MCV is high, the myeloid erythroid ratio is less than 1 to 1. In these cases, there is erythroid hyperplasia, especially when the MCV is high because of a B12 or a folic acid deficiency. Anemia due to hypoproliferative bone marrow conditions like marrow damage due to infiltrative disorders like sarcoidosis or aplasia, iron deficiency, and a reduction in the stimulation of bone marrow production due to chronic kidney disease, inflammatory processes, and hypothyroidism cause normocytic anemia. While maturation disorders like cytoplasmic defect disorders or nuclear defect disorders cause the MCV to be either high or low. In these cases, the myeloid erythroid ratio is less than 1 to 1. Coming to cytoplasmic defects, these are usually associated with a low MCV, and it's due to iron deficiency, thalassemia, sideroblastic anemia, lead poisoning, and B6 deficiency. Nuclear defects in which the MCV is high include folic acid deficiency, B12 deficiency, drug toxicity, and refractory anemia. When there is a loss problem, if the reticulocyte count, that is the corrected retics, are not very high but high, we would think of a bleed. But if it is very high and associated with a high LDH, a high indirect bilirubin, and a low haptoglobin, we think in terms of a hemolysis. Hemolysis is further classified into intravascular and extravascular hemolysis. In intravascular hemolysis, the serum hemoglobin, free hemoglobin, is elevated along with the urine-free hemoglobin. Methemalbumin is elevated, which is detected by the Schum test. And hemosiderin is elevated both in the serum and in the urine. In extravascular hemolysis, you have a palpable spleen, which is where the destruction takes place. Causes of intravascular hemolysis include paroxysmal nocturnal hemoglobinuria, paroxysmal cold hemoglobinuria, microangiopathic hemolytic anemia, toxins like copper sulfate, venoms like recluse spider, transfusion reactions, trauma, infections like malaria and Clostridium. Causes of extravascular hemolysis include hemoglobinopathies, enzymopathies like G6PD deficiency, membrane defects, and AIHA, which is autoimmune hemolytic anemia. In autoimmune hemolytic anemia and in G6PD deficiency, you have both intravascular and extravascular hemolysis. Now, let's just go through the differences in the findings that we get in these 4 different conditions. Iron deficiency anemia, your MCV will be on the lower side most of the time. But many times it's confusing because the MCV can be normal. And this can be because there is another deficiency associated. There are many patients who have dual deficiency with both iron, folic acid, and B12 deficiency. In those cases, you'll definitely have a normal MCV count, MCV. In inflammation, like in anemia of chronic disease, I know it's one of the causes of microcytic anemias, but many times the MCV is normal as well, even in anemia of chronic disease. That's to the range of 80 to 90. In CKD and in hypothyroidism, the MCV could be normal. It could even be macrocytic. It could be larger than 100. Serum iron level is very low in iron deficiency. It's less than 30, but serum iron has a diurnal variation. So we actually see all these levels together in order to come to a conclusion as to what kind of anemia the patient has. Serum iron can be low even in chronic inflammation, anemia of chronic disease. It can be less than 50. So TIBC is elevated in iron deficiency anemia, and it's low in anemia of chronic disease and inflammatory conditions. And that is actually one of the main distinguishing features between iron deficiency and anemia of chronic disease. Transferrin saturation is iron divided by TIBC. And this is low in iron deficiency anemia. The transferrin saturation will be low even in anemia of chronic disease. But the main differentiating factor is a TIBC, which is iron binding capacity will be low in inflammation, and ferritin will be either normal or high usually in inflammation or anemia of chronic disease. But a ferritin that is low and less than 15 is diagnostic of iron deficiency anemia. Many times the patient has both, and he has an underlying chronic inflammation, and because it's a negative acute phase reactant, ferritin can be abnormally high in iron deficiency. So we have to look at the other factors as well. Bone marrow iron stores are the gold standard test for diagnosing iron deficiency, but we don't do it all the time. It's only when there is a confusion. In CKD, ferritin levels are usually normal, but they can drop to low levels and the patient would need IV iron therapy. In otherwise serum iron, TIBC, transferrin saturation would be normal in both hypothyroidism and in CKD.